Welcome to the virtual roundtable discussing Medicaid Managed Care contracting. Before we begin, as a reminder, at the bottom of your screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in background that could cause issues. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters, and make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast, and I'll turn it over to Reggie Kadwani.
Hello, everybody. Welcome. Thank you so much for being with us to discuss Medicaid Managed Care contracting. Let's go to the next slide. You should have all received the issue brief that this roundtable is associated with, but if you didn't receive it or haven't had the chance to review it, it is available on the platform's library. It is also online on the Lung Association's website at lung.org/cessation-TA. We really do appreciate your participation in today's webcast. We recognize that so many of you working in public health have increased workloads due to COVID-19. I'd also like to take this time to acknowledge that during these times, most of us, if not all, are working from home. So please excuse any background noises you may hear on our end. We have new coworkers, whether they're family members or pets. We live in noisy neighborhoods, so just wanted to put that out there. Next slide. So today, Claire Brockbank and Michelle Paterino of Segway Consulting are our facilitators for this roundtable. They worked extensively on the issue brief and will dive deeper into the information provided in that brief, along with guiding our discussion later on. Claire is a founder of Segway Consulting, a healthcare strategy and business development firm. She has gained her broad perspective on healthcare through work for the U.S. Congress and state governments with national and local insurance carriers and health plans, as an executive with an employer coalition and several healthcare startups. Claire has worked with the Centers for Disease Control and multiple state governments to identify and analyze coverage and reimbursement of services compatible with the nation's public health agenda. Claire focuses on using that information to promote mutually beneficial health and wellness strategies between public health and private carriers. She has worked on tobacco coverage issues for the last 12 years. Michelle Paterino has worked in tobacco control for 20 years after 10 years of learning the ropes at a regional health plan. In Colorado, she directed the state tobacco program's contract for healthcare provider engagement, which included individual provider guideline education and large health systems change grants, in addition to quitline sustainability. She has brought that experience to several states since Colorado ended its program and worked with the CDC and the Lung Association on projects with a national focus. When she's not working on tobacco projects, Michelle also works with her state Medicaid agency and state health benefits exchange. Today's roundtable panel includes Theresa Brown, Karen Brown, and myself, Reggie Kadwani. Theresa and Karen really helped in providing real-life examples of what happened in New Hampshire and Michigan with respect to improving tobacco cessation coverage through the MCO procurement process. Theresa has been with the New Hampshire Tobacco Prevention and Cessation Program for 20 years this October. Primarily, Theresa manages the cessation activities for the program, including the New Hampshire Tobacco Quitline contract with National Jewish Health, and oversees tobacco treatment workforce development for healthcare professionals. Karen has been a public health consultant with the Michigan Department of Health and Human Services Tobacco Control Program since 1999. Her primary responsibilities include serving as lead staff for training and implementation of tobacco dependence treatment services to local health departments, healthcare systems, and businesses throughout Michigan. She also works with Medicaid to increase member access to tobacco dependence treatment through policy and quality improvement initiatives. And the last person on the slide is myself, Reggie Kudwani. I am the National Specialist for Cessation Policy at the American Lung Association. I've been with the organization for a year and a half, and my primary responsibilities are to manage 2 of our federal cooperative agreements with the Centers for Disease Control and Prevention, both of which are related to tobacco cessation coverage. So as I mentioned, the issue brief is available at lung.org/cessation-TA. There will also be a recording available that you will be sent in an email to the link. And then please feel free to enter any questions during the presentation, and we will do our best to answer them live towards the end or send you an email later on. And we can get started with our first polling question. So if everybody could please take a few seconds to read that question and answer. Okay. Not sure why it's not working, but we can move. Okay, lovely. So for the most part, people are either somewhat knowledgeable or not very knowledgeable on this process. And that, to me, is great news because hopefully that means you all will be able to learn a lot through this roundtable and ask all your questions. And hopefully towards the end, we can see some knowledge change, which is, of course, what we hope for. So now we'll kind of get into the meat of the issue brief, into Medicaid Managed Care contracting to improve tobacco cessation coverage, and also just the background of what even is a comprehensive tobacco cessation benefit. I think it's really important to level set. So when we look at a tobacco cessation benefit, what we want is a comprehensive coverage. And that means looking at all 7 FDA-approved tobacco cessation medications and 3 forms of counseling. This is considered a comprehensive benefit by the Treating Tobacco Use and Dependence 2008 update, which is the most recent clinical guidelines we have on tobacco cessation coverage. And all of these treatments are considered first-line treatments in helping smokers quit. Unfortunately, we do tend to see a lot of barriers in accessing this care. And again, I'm just going to go over this very quickly. We're not going to spend a whole lot of time, but just really important to level set. Cost sharing includes co-pays, co-insurance deductibles, so any type of financial barrier, especially when talking about the Medicaid population, can have very devastating impacts. Any prior authorization, so needing to get that additional permission from your insurance company or Medicaid office in addition to getting a prescription from your provider, is considered a barrier. Limiting the duration a person can have a medication, limiting the number of times they can quit in a year or in their lifetime, just doesn't recognize that quitting isn't linear, and it can take people a lot of times before they're successful in quitting. Limiting the amount of money an insurance company or Medicaid office will pay for someone's cessation medications is a dollar limit. So that would be like an insurance company telling somebody they have $500 to quit that year, and once they reach that $500, everything comes out of pocket. Additionally, as mentioned before, all of these medications are considered first-line treatment, so step care therapy really is a barrier in this case because it means an insurance company or Medicaid department will require a patient to try one type of medication and fail on that before trying another one. And then the next barrier is required counseling. So we know that the most effective way for a patient to quit is using a combination of both medication and counseling. However, making counseling a requirement does have an unintended consequence, especially for a lot of patients on Medicaid. Getting to counseling alone can just be a barrier, whether it's being unable to pay for transportation or childcare for you to get to a face-to-face counseling session or a group session, or just paying for minutes on a cell phone for maybe a quit line call. All of those can be barriers. Next slide. So as we are discussing Medicaid, I thought it'd be really important to go over kind of what does coverage look like in standard Medicaid and in Medicaid expansion. So the passage of the Affordable Care Act had a lot of new requirements for Medicaid. For standard Medicaid, Section 2502 of the Affordable Care Act removed tobacco cessation medications from the exclusions list. So states aren't allowed to exclude tobacco cessation medications, but they are still allowed to charge co-pays and put in place other barriers. Additionally, counseling wasn't addressed. There are different provisions in place for pregnant women, which also went into effect in 2010. The requirement is that all pregnant women under Medicaid, standard Medicaid, are required to have a comprehensive cessation benefit with no cost sharing. And this includes both pharmacotherapy and counseling. Next slide. Medicaid Expansion is a part of the Affordable Care Act, which requires people to be covered wherever state Medicaid programs left off up to 138% of the federal poverty level. So Medicaid Expansion doesn't have any other requirements for somebody to be eligible, just that financial one. So 138% of federal poverty, what does that look like? So for an individual, that looks like $16,753 a year. And for a family of three, that looks like $28,676. Due to a court case, Medicaid Expansion is optional for states, and as of today, 38 states, including D.C., have expanded Medicaid. When talking about the costs of Medicaid Expansion, the federal government picks up more of the cost of the Medicaid Expansion program than the standard Medicaid program. Normally, the federal government picks up anywhere between 50 to 73% of a state's Medicaid expenditure, but for expansion, the first year it picks up 100% of the cost, and slowly over the course of this decade, that has come down to 90%, and it'll be at 90% for perpetuity. So the federal government is picking up a decent chunk of the tab. The ACA did provide that the benefit package for the newly eligible Medicaid population must include the 10 essential health benefits. And one of those essential health benefits is preventive and wellness services, which tobacco cessation falls under. Next slide. So what is that preventive services requirement? It requires any service given an A or B rating from the United States Preventive Services Task Force to be covered with no cost sharing or prior authorization. Tobacco cessation for adults has an A grade, and that is for all forms of counseling and all 7 FDA-approved cessation medications. I think a big thing to note, though, is that with respect to this, states are responsible for the implementation of this requirement. Next slide. So because clinical guidelines aren't necessarily able to be translated perfectly to insurance coverage, the Departments of Labor, Treasury, and Health and Human Services issued frequently asked questions in 2014 to translate what the clinical service guideline would look like into insurance coverage. So it reaffirms that people must have at least 4 sessions of individual, group, and phone counseling per quit attempt, at least 90 days of all FDA-approved smoking cessation medications when prescribed per quit attempt, at least 2 quit attempts per year, with no cost sharing and no prior authorization. Next slide. So that's kind of all the level-setting background information I have, and I will now pass it on to Michelle Paterino to really dive into the meat of our issue brief and what we really discussed. Michelle.
Thanks, Reggie. So good morning, everybody. Hopefully some of you have seen the issue brief. We know it's available now. Whether you have seen it or have plans to take a look at it later, we're not going to go in depth and tell you everything that is there. Obviously, you can all take a look at it, but we're going to spend the majority of our time just really talking about that procurement process that it looks like the polling told us that we want to bring everybody up to speed on a little bit, and then, of course, make sure that you have time to listen to our subject matter experts. So I am making the assumption that pretty much everybody listening to us is in a state where your Medicaid is delivered through managed care. And the reason I can make that assumption is that as of 2019, 40 states, including Washington, D.C., were contracting with managed care companies to deliver at least a portion of their Medicaid program. So most of you are definitely in that boat. Where we want to focus, actually, let me back up. Some of the sources in the issue brief will give you a lot more background on managed care and some of the definitions. So if you need to do a little bit of studying on managed care, that is available to you. But we're going to focus on procurement today. So we have laid out, we've got 2 slides here that walk through the steps in the procurement process, really from the starting point of when managed care organization contracting process begins, whether it is a new process in a state or whether it's a rebid. We've got the process beginning. There may or may not be a request for information. The feedback from that is evaluated, then used to develop an RFP or an RFA, or you may even hear of an ITN, an invitation to negotiate. that invitation is posted, and then the proposals are evaluated and bidders are selected. Contract effective date comes a couple months later, and there's startup and implementation. So it looks relatively straightforward here, and many of you may be familiar with the contracting process, perhaps for selecting a quitline in your state. A lot of it is similar, but there's also a lot more complexity in MCO procurement. If you think of choosing quitline services, that's one defined and related set of services. When you're shopping for MCO coverage, you've got dozens and dozens and dozens of activities and programs like that quitline that go into it. So it's a much more complex process. So when Claire and I were laying out this timeline of what procurement looked like, we struggled a little bit. We wanted to put the average amount of time these things take, but it just varies so much that we decided the best way to illustrate that would be this real-world example that is mentioned in the case study, and I'll go through this in a little bit more detail. Claire and I have worked in the state of Ohio for a couple of years, so we keep tabs on what their Medicaid program is doing. So between communications from Medicaid, keeping an eye on the press, looking at their website, we know this one pretty well. So the steps to new procurement in Ohio, and actually let me just start by saying the last time the MCOs were contracted in Ohio was 2011-2012, and they cover over 90% of the beneficiaries for Ohio Medicaid. So from 2011-2012, fast forward to February 2019, and that is when the governor asked the Department of Medicaid to ensure best value in managed care and to rebid the MCOs. So from that February request, the first request for information was developed by the department, and it was released in June of 2019. And that request for information was to gather public input from individuals and providers on the design of the program. So that, was about 6 months later. In the following February, there was a second RFI. That one was focused more on potential bidders, advocacy groups, associations, and groups like that. Both of the RFIs closed in March 2020, so about a year into the process. There are some new notes on the Ohio Department of Medicaid website about some program design decisions that have been made based on feedback in the RFIs. So obviously they evaluated that information and have made some decisions. So the next step now is we're waiting for the RFA, request for applications, to come out in Ohio. So now we're like a year and a half after the process kicks off, still waiting on that formal RFA to come out. There's a newspaper article that I cited here, the red bullet. That newspaper article says that the goal is to have this completed by July 1st, 2020. It's not entirely clear whether that means that they'll just have the new plans selected or whether those new plans would actually be serving people by July 1st, 2021. So even best case scenario, if that was when they should be serving the Medicaid beneficiaries, you can see this was a 2.5-year process from start to end. I still think that is pretty challenging, so it'll probably be even longer. So from the time they started to when they're going to have those contracts in place, clearly a long process, and I would say that's pretty typical for most states. So based on that graphic that walks you through the steps and this sort of real-world description in Ohio, let's talk about where the opportunities are to really influence the procurement process so that you can move the needle on that comprehensive tobacco cessation coverage benefit that Reggie described to start us off. There's the process of developing the RFI that really signals to the marketplace and the potential bidders what Medicaid cares about. So you could potentially get questions into an RFI about how tobacco cessation is covered or tracked or monitored or approved in the MCO. Then there's developing the request for proposal or request for application, and the responses to those proposals become part of the contract. So anything that is promised in that proposal gets done. There's the process of evaluating a proposal, where a state health department might be able to look at how the different programs are described and, provide some guidance and some information on what looks to be the best coverage. And that may include things like the barriers that Reggie described, whether there's prior authorization or step therapy or something proposed. And then across all of these, we have the contract language. And the contract language is typically pulled together before you do the RFP, because usually you see a draft contract as part of the RFP itself. But the contract language may include the coverage requirements. It may talk about how you have to identify members or report on that. It may talk about quality improvement programs within the managed care organization, or what quality measures have to be reported. So there are a lot of places that you can impact tobacco cessation coverage there. And now we are going to talk about the real case studies that we covered in the issue brief. These are the 3 states that we talked to in terms of their role in this procurement process and what kind of successes they had. So as Reggie mentioned, we have Karen from Michigan with us, and we're going to hear from her on the roundtable. And the case study really describes in a little bit more detail how Michigan came to the point of having standard contract language for the managed care plans on cessation treatment. And that includes counseling and medications, specifies no prior authorizations there, as well as sit-line services. And one of the unique things that Michigan has done, the Department of Health has done, is to participate in identifying enforcement issues and working with Medicaid to make sure that all the managed care plans are providing what they are required to do. So that's been a unique role for them, and that's been really valuable in Michigan. We are also going to talk to Theresa from New Hampshire, and we gave some more detail in the issue brief on the New Hampshire experience. New Hampshire was a 618 state, and that resulted in having RFP and contract language on cessation coverage, as well as their performance measures. And one of the unique things that Theresa is doing is working with the managed care organizations on their processes to report and improve the performance measures that were included in the contract. So those are 2 of our great examples. Third really good example that we covered is the Florida partnership. Florida was a little bit unique because they didn't get engaged specifically as part of that procurement process and influence the questions or the contract language, but after the invitation to negotiate was done in Florida and the managed care organizations were selected, the Florida Department of Health was able to get engaged in a quality improvement process that was really central to the invitation to negotiate in Florida. Medicaid told the plans that, pardon me, my other phone line is renewed. Medicaid told the plans that they needed to pay attention to potentially preventable events and really do a lot of work around that. It was a real central feature. So the plans have to look at unnecessary ER visits and hospitalizations and readmissions to the hospital and figure out very strongly quality improvement processes to improve that. Florida Department of Health has been able to work with those health plans and identify what their tobacco programs look like and really help them to understand the impact that tobacco cessation could have on those potentially preventable events. So again, grateful for the folks in Florida, and there's more detail in the case study on them as well. So those are 3 of our successful procurement partnerships. And, of course, I can hear many of you saying that's terrific, but I don't have 8 or 9 years to wait to make that happen. So what are the opportunities that I can use to address cessation coverage outside of the procurement process? And so we gave you some answers on that as well. If you miss that sort of golden opportunity, there are some non-procurement cycle options, and they really focus on educating Medicaid and really sharing the information that you have so that you're ready to move. In the 2 examples that we gave, South Carolina, they were able to use a bulletin to standardize tobacco cessation coverage across the 5 managed care plans. South Carolina was also a 618 state and took advantage of that relationship. So there is an entire case study written up on the South Carolina experience. We give a link to that in the issue brief. So if you want to dig in and see more detail about that, that's available to you. But the other state we looked at was Oklahoma, which was fairly unique as well. Again, they used the public measures to educate Medicaid. So they looked at things like BRFIS, and they calculated the cost of not addressing cessation in Medicaid. And then they provided the cost data, ROI data, and experience from Massachusetts. That's a case study that I think a lot of folks know about when Massachusetts expanded the Medicaid program. And so they leveraged that knowledge by having some staff placed within Oklahoma Medicaid. And that staff was funded by the Post-Settlement Endowment Trust, which was established in that settlement agreement. So they put their staff within the Medicaid agency, and they had some rulemakers that facilitated some of the program there too. So another great example of working outside of the procurement process that's available. All right, next we're going to talk about lessons learned, and we were able to get to some common lessons across the states that worked in the procurement process as well as outside of the procurement process. So these are the really common themes that we heard. The first one obviously is playing off the real estate adage that a location, it's all about the relationship. The things that we heard from the folks in the states that are highlighted is make sure you can speak the language of Medicaid. You need to know what Reggie was referring to about the expansion Medicaid, Medicaid for pregnant women, know what is currently covered. You need to find a champion within Medicaid and really try and stay connected and share information with them. One of the things that we also heard was, you really have to have a little bit of grace, if you will, while you're dealing with folks for Medicaid. And particularly now, they're under as much stress, I think I should say, as the folks in public health are. While the states are slashing budgets, facing shortfalls, furloughing employees, they also are going to see a huge increase in the number of folks who are enrolled in their program. Depending on the source that you look at, they're saying between 5 and 18 million more Americans are going to enroll in Medicaid during the COVID emergency, sort of with existing staff at best. So certainly in the next year, having some grace and working with the Medicaid staff is important. But overall, that really partnership perspective there is super important. Remember why the Medicaid population is key. Obviously, I think everyone on this call knows that the prevalence of tobacco use in Medicaid is higher than just about anywhere else that we're looking. Using existing tools and language from other states. This is really the don't reinvent the wheel advice, I would say. There are tools like the ROI calculator or the public performance measure data that you can leverage. There's language, including some of the benefit coverage language that we reviewed and things from other states. We actually provided you some of the contract language within the issue brief. There are subject matter experts like the folks from the American Lung Association who are supporting this, and just the peer networking opportunities that are available to you. Definitely capitalize on those. Simplifying the use of the quit line is great advice for any state that wants to be poised to do some more work with Medicaid Managed Care. Make sure that the online referral capability and those processes are as simple as they can be, and then think about what kind of reports could be available to managed care organizations to give them the value of those quit line referrals. That's a great tool to use. And then don't let purpose be the enemy of good. I think that's the point there really is that incremental change can be better than no change. So, don't wait to get all 9 items covered if you can move the needle and get the majority of that done. So I think that is the most important themes that we heard, and we can hear more about that from the panel itself, which we're excited to introduce. My colleague and partner Claire is going to introduce the panel one more time, and then she'll facilitate our discussion and take the questions.
Thank you, Michelle. And I know the sound is a little bit spotty, so I think they're working on fixing the mic, so bear with us here. As already introduced, and hold on a second, I'm looking at questions and not introducing the panel. So just a reminder, there is a Q&A box on the bottom of your screen, and you can enter questions into that, and we'll be keeping an eye on those while we're also posing some questions to our panel. I'm going to start with some of the questions that have already been posed and then segue over to our panel. And our panel is Theresa Brown, and she is with the New Hampshire Tobacco Prevention and Cessation Program. You heard her bio from Reggie earlier in the presentation. And Karen Brown, who is with the Michigan Tobacco Program. She is a dependence treatment coordinator. Both have long histories with their state and provide a wealth of information. Reggie Kudwani, who you heard from also, will also be on our panel. I'm going to start, though, with a couple of questions that were posed in the Q&A. We had one question specifically about what billing codes are used for tobacco cessation counseling. The person posing the question is an LCSW and uses psychotherapy codes, but indicates, of course, that physicians can use E&M codes. Rather than expand upon that on this call, I'm going to recommend the American Lung Association has a billing guide, which actually Segway Consulting helps produce, and a mental health addendum to that billing guide all around tobacco. So I would recommend that you take a look at that, and then if you have further questions, reach out on the billing specifics. Typically, just as a caveat, when a managed care plan contracts with a state, they may enter into a flat capitation contract, which means they're paying all of the providers themselves, and they're receiving a flat amount from the state for each person who enrolls in their plan, in which case the billing protocols are going to be between the provider and the managed care plan, not necessarily between the provider and the Medicaid agency. However, the billing codes are all the same. We also had a question about if the state offers a Medicaid Managed Care plan and a fee-for-service, would they still put out an RFP? And again, yes, many states still have a small fee-for-service section of their Medicaid program, some for particularly high-need cases, but they do still put out, if they contract with any Medicaid Managed Care plans, they have to put out an RFP. Okay, so with one of our questions, I'm going to ask Karen to address this, and then Theresa, if she wants to add anything, asks if it's typical for the RFP to require the vendor to do the bid for both cessation services and medications, or do they cover all meds with an RX through their PDL? Actually, the American Lung Association has an issue brief on uniform prescription drug list or preferred drug list, and you can refer to that also. But Karen, in Michigan, did the bid include both medications, or did they sequester out the medications to go through one state PBM? And did you have any input on that process?
We did split it. So the managed care was one RFP. Our PBM was a separate. I had no input on the PBM contract itself. However, I have attended some of the PBM meetings over the years, and they do change policies throughout the year. So, and they recently have done some updates for us. So that wasn't really contract specific. We were able to do changes without having having to do the whole RFP.
Yes. And what about you, Theresa? Is the contract in New Hampshire, does it include the tobacco meds, or are the tobacco meds provided by a state pharmacy benefit manager?
So in New Hampshire, can you hear me?
Yes.
Okay. In New Hampshire, it's all part of the same contract. There's a preferred drug list that lists a bajillion drugs, and cessation medications have their own section. And the other tobacco treatment, too.
Great. In Ohio, in the move they're making, before the ACA, the states couldn't get rebates for drugs provided by Medicaid Managed Care plans. So many states wanted to offer the medications themselves because rebates are a really important way for Medicaid to keep their costs down, including on prescription tobacco cessation drugs. The ACA changed that, and so we saw a number of plans moving towards letting the managed care plans manage those drugs so they'd have the information in-house. And now some states are moving back the other direction. Typically, tobacco cessation drugs are not a controversial component of that decision in the contract. One question I have that I'd like to get some input while others input their questions into the Q&A box is again, let's start with Karen and then go to Theresa, and the next time we'll do you have recommendations on what kind of staff person to work with at the Medicaid agency, which kind of person to sort of target in building a relationship?
Wow. I think that is really variable. I had the good fortune to work with the Medicaid director or for managed care, not for the whole Medicaid portion. So we have 11 managed care plans, and then we have straight Medicaid. So I was working with the director of Michigan Managed Care to get this started. I also have worked with some of our quality improvement people. Those seem to be really good contacts because they're motivated to do this. So those are probably my two biggest ones. But
okay,
I think yeah.
We definitely heard from Florida and Oklahoma who aren't represented, and then Theresa, I'll turn to you to get your perspective, that those relationships are super important, and some of them took years to develop, of very patient sort of providing assistance, and they do seem to often be with the managed care team and folks. Theresa, what was your experience?
Some of each, because we hadn't been able to get a relationship started, so we continuously worked on those relationships, and then by happenstance, the procurement process was announced, and they developed a Department of Health and Human Services procurement team, and we were invited to the table. Well, the bureau chief of the entire Division of Public Health Services was invited to the table, and of course she was a great champion of ours and promoted promoted the need for evidence-based cessation services. In the background, we were always trying to go in the back door, and QI was one of the back doors we were trying to use because we were familiar with some of the staff who worked over there. So again, all of the above.
Mm-hmm. Which I think reinforces the point that Michelle was making, and that is in the case study, that this is a Medicaid managed care contracting is use that sort of proverbial, the blind wise men around the elephant. There's a lot of different entry points. We saw in Florida that they really used the QI initiatives as a way to demonstrate that there were ways that tobacco could assist the health plans reach their QI measures, and so that's an important dimension also. So one of the questions we get asked a lot, and Reggie, I'm going to direct this to you at a national perspective, and then turn it over to our panel. But why do you think it's better to work with Medicaid to standardize it across a contract or an initiative than to work individually with each managed care plan? Do you have thoughts on that in terms of what you're seeing nationally?
So Reggie's actually having some technical problems to get off mute, but my name's Angie Julio. I work very closely with Reggie, and so I'm happy to address that kind of from a national perspective. And I think that's a great question and kind of gets to the heart of why, using the contracting process is so important. I think one of the things from a national perspective that we see is managed care is a neutral thing in and of itself. It can really have really great benefits, but one of the drawbacks of having managed care from a state per state is you get an unequal or variation of what the benefit is. And if you can standardize that benefit from even from just a state perspective, providers in the state will know that, a comprehensive cessation benefit is available to Medicaid enrollees in that state, and it just becomes much easier to message. And then kind of after you get that coverage piece, then you can go on to the health systems change piece and really work on implementing that benefit and making sure providers know it's available, patients know it's available, family members know it's available, so they can really work to try to make sure everybody has the opportunity to quit, to make sure that patients know that they have options. So I think from the loan association perspective and from the national perspective is, as states move towards more and more managed care, really kind of helping prescribe, and I didn't mean to sound cute, but, to really kind of list out what the state expects the managed care plan to cover in terms of cessation, both in terms of barriers as well as in terms of coverage, is really important so that, the uniformity is really important, is I guess what I'm trying to say. Did that answer your question?
Thank you, Ann. Yeah. And Theresa, I know in New Hampshire, while you were able to create, a framework that goes across the plans, you've been working with them somewhat individually on the rollout. Do you want to sort of explain the mix of statewide and individual plans that you have found to be effective?
Sure. Well, it has to be because it's a state contract. It has to be a standardized state plan for it all, and then. However, each MCO is an individual company and has individual workflows and individual reference frames for things. So once the standardization is in the contract and our standard expectations are out there, then we want to get on a more personal level and really explain that our intent is to remove the burden from these disease and care managers from having to figure out how they're going to deal with not just the diabetes but the tobacco as well when they're talking to somebody with comorbid conditions, which is quite common amongst this population. So we framed it as we're trying to relieve your burden. How can we do that best and easiest for you given your own workflow?
I think that's super helpful. And I actually also think, Theresa, if you want to take just a minute, Michelle talked about being considerate of the enormous pressure that the state Medicaid programs are under with the impact of COVID-19. And you have straddled that environment. So do you want to just speak briefly to that? Because I know you started and then, you paused a little bit, and how has that played out for you?
Sure. Well, the contracts went into effect, the new contracts went into effect a year ago, August. So next month they'll be a year. And in the grand scheme of things, we understood that they had to go through the orientations for financial and things like that. And we were sort of promised, kind of promised an audience with the three MCOs in January of 2020 to understand their workflows. They can understand what our expectations was, so forth and so on. It didn't happen just because things got held up and bureaucracy and things like that. So anyway, fast forward to March, and we had just barely gotten feedback from one of our three, we're small, three MCOs that they said they were working. The compliance officer contacted us and said, hey, we are working to comply with this, but we don't understand what you want. So we had started some really good phone conversations with this compliance officer and teamed up with their care disease manager director. And that literally was March 3rd, our last conversation. And when COVID broke, they went home to work, we went home to work, and, everything kind of broke loose. So again, fast forward to last month, and we asked the clinical director of Medicaid MCO Services if we could reapproach and start asking if they could talk with us again. And because we always are, try to be courteous of the Medicaid approach before we just jump in with both feet. So she said, definitely recontact them, say, it's time to revive this compliance movement. So I did, and and that's where we're at right now. But it took it took some time to let everybody readjust and get back to the table. And we're still not in the office yet. I don't know if they're back in the office yet. So we have on the calendar right now, we have appointments with all three MCO compliance officers and their directors of care or disease management, where we will lay out what we put in writing and get feedback from them, and try to negotiate how this is going to work for the next 2 years.
That's awesome. Thanks, Theresa. Karen, in your work in Michigan, do you find that you're working more with the Medicaid team on some of these moving parts, or more with the individual MCOs as actual deliverers of these services?
Currently, much with the managed care team. Originally, it was more with the MCOs when we first started out. But that has changed over time. This has been in place for pieces of it for over 10 years.
Yes. So one of the things that we talked about was, don't reinvent the wheel, and that sometimes it's super helpful to have contract language ready, to have examples of quality improvement programs ready, and the kind of information you have so that it becomes these things often happen quickly. You wait and wait and wait, sometimes for years, and then the time is nigh. And that was certainly the experience we saw in Ohio when this request for input was made. So where do you all recommend? Theresa, I think you particularly said you really took advantage of materials to use it. So how would you recommend people who are thinking about wanting to put together a portfolio of things in order to influence the procurement process, to be ready? What would you recommend as a source? And Theresa, I'm going to start with you, and then I'll go to Karen.
Okay, thank you. So the North American Quitline Consortium has an entire section dedicated to these efforts, and it dates all the way back to, I think, 2010, 2011, when Deb Osborne started the first work group, and it really goes step by step of the homework that you need to do, and you really need to do that homework, because as you do that homework, you do learn their language, and then I highly recommend joining whenever you can. It's not a closed group. Whenever you can, join the current NAC public-private partnership work group. We meet once a month. Tracy Strader is the facilitator of that, because you get all phases. You get a ton of states in all phases of rolling this out, and this is exactly where we went to. I totally threw my hands up and said, Ann DiGiulio from ALA and NAC group, and please, here's our opportunity. Guide me as we go forward. And they proofread things, and they redlined things, and it was just I was so fortunate, because things did move quickly, and they wanted Medicaid wanted feedback yesterday, and this group was just fabulous at taking what something I had written, and then and redlining it enough so that putting that gold standard language into the contract happened, which is like, pinch me, am I dreaming? So, but it did happen.
Mm-hmm. Mm-hmm. So I think that's a really good point. ALA has an enormous amount of technical assistance and material to provide, as well as NAC and other resources. The 6 and 18 produced material also with the CDC. So there are definitely resources out there to feel like you don't have to reinvent the wheel. Karen, I'm going to guess, since you've been around for 10 years, that you are more in the position of sharing your material probably than soliciting material. Is that a fair statement?
Oh, that's very correct. Yeah, we kind of had to make it up as we went along. One of the things that was really helpful for us was the CAPS data. And that's the first thing we took to our Medicaid Managed Care director that kind of opened her eyes, because she did not like what she saw. People were not asking about smoking. They were not, the providers were not addressing it. And then I also brought some background material showing what we already knew, because I'd been working with individual managed care plans for a while, and we had put together a grid of who covered what, and kind of showed her that so she could see where all the gaps were. And one of the things we kind of discovered, there was a lot of physicians, providers in general, were not referring people for smoking cessation because we, at that time, had 13 managed care plans, and each one was completely different in their benefit coverage. And most of the providers said, just throwing up our hands, it's too difficult. We can't track who gets what. It's ridiculous trying to refer people because we don't know if they're going to get it much of anything. And bringing that to the attention of our Medicaid Managed Care director was very powerful.
That's a great point, and I think it goes to some of the material in the case study that talks about different ways to make your case, right? And sometimes it takes a while to make your case, but Karen's just talked about using the CAPS data where performance was pretty spotty, looking at some of the other data, getting feedback from providers that say the reason we don't do it is because it's inconsistent across plans, which again goes to that, building the case for contract language that's uniform so providers can know that what's covered is covered, if you will. So thank you to both of you. So I'm going to do a quick check. Give me 1 second. I believe that's it on the questions. We have a few other billing questions, but again, since that's not really relevant to the managed care contracting per se, I'd really recommend those resources that are on the ALA website. I believe Reggie has figured out how to unmute her phone now, or not figured out. I think it was probably a technical issue. So with that, unless there are any other questions that people want to quickly type into the Q&A box, I am going to turn it back to Reggie with the ALA.
Hi, can everybody hear me?
Yes.
Oh my gosh, I'm so sorry. My phone just decided to freeze on me, but that is why Anne was there as my backup. This is great. So I just wanted to quickly say thank you so much to Claire and Michelle for working on the issue brief, and for Theresa and Karen for providing them with those real-life examples, for working with them on that, and for just all of you being on this webcast and providing your expertise. I hope everybody was able to put in their questions. If not, feel free to email. But before we formally wrap up, I'd like to go to our polling question. Sorry. So same question as before, but we're just trying to see maybe this just how helpful this information has been to y'all. Okay, let's see. Okay, so a lot of people did jump to very knowledgeable and somewhat knowledgeable. We still have some people who are not very knowledgeable, and that's okay. I am seeing a knowledge change, and that is great news. Please be sure to take a look at the issue brief and read it in depth. Please feel free to reach out to myself, to Anne DiGiulio, with any of your questions, and we will make sure you get to the right person. Thank you so much for joining. I know times are tough right now. Things are a little crazy, and I just so appreciate everybody joining us for this webcast. We do have an assessment. We, always look for ways to improve our roundtables, our webcasts, etc. So please be sure to fill out that assessment. It should pop up on your screen at the end, and also should be sent out in an email. Once again, please feel free to, yes?
Reggie, it's Theresa. Can I just put in one more plug?
Of course. Of course.
I'll tell you that I was one of those people. I bugged Karen, like Karen said, she's been in this for a long time, and I was always yanking, Karen. So please, if you have any questions, feel free to contact me as well, because we've had fits and starts. So please, I want to put that out there that please contact me because I got so much support from others. So I'm happy to support anybody who wants support.
Thank you so much. Our doors are always open, and please, once again, just please feel free to fill out that assessment, take a look at the issue brief, and I hope everybody stays safe. Thank you.
Thank you.
Thanks. Thank you, everybody.
This concludes today's conference call. Thank you for participating. You may now disconnect.